All right. Well, good evening, everyone. Welcome to our first family community workshop of the school year. Today, we are excited to welcome Ms. Katie Schroeder-Smith, one of our amazing occupational therapists who will be presenting for the evening. Katie?
All right, hello. So I'm going to be talking about strategies to support mealtime independence, and I'm going to try to share my screen now so you guys can see the slides, and there'll be a link in the, I guess we can put it in the chat box, and then we'll also share it via possibly email. Sarah, I don't know. Okay, so let me get this up. Let's see. All right. So we can see this?
Yes, we can. Thank you.
All right. Thank you. And I do have my Chromebook tonight, so I cannot see you guys. I did leave my laptop because I can't carry everything, and I don't know what I was thinking with the Chromebook, but it's okay. So just please speak up if you have questions because I can't necessarily see your face as I'm sharing my screen. I want to mention that Yun Kim, our other OT, one of our other OTs, helped with some of these slides because we presented some of this information to our occupational therapy and physical therapy department this year. So some of these slides came from Yun, so I wanted to acknowledge her in this as well. So I'm going to go on. And I don't have the objectives listed here. I will add those into the slides because those got mixed around when I merged the slideshows together. So I'll throw those back in, but I'll just kind of go over those. Basically, we're going to talk about what does participation and function look like with mealtime. And it can depend for a child who is fed orally. I'll even talk a little bit about tube feeding. And then we're going to talk about the anatomy and physiology of eating and some things that can go wrong with that, as well as what can go right with it, hopefully. We're going to talk about the development of feeding, the normal development, and then sort of where some students or kids may be in that phase of development, and then how to encourage independence no matter what stage of development we're in. We'll talk about different kinds of spoons, different kinds of cups, different kinds of plates, all that kind of stuff. Some strategies just to promote the best experience. And then I'm hoping, I would love to have, if we had lots of parents here, that'd be awesome to share your experiences, because as parents, you guys are the experts on your kid. You have had them, their whole life, and you've fed them many, many meals. So as therapists working in the school or as teachers in the school, we have limited, experience and observation of your kids at school. So we definitely rely on your observations, your opinion, and also as well as medical information. So I'm going to dive in here. So participation. What does it look like for you? This definitely depends on your family, your routine, your child, and their needs and strengths. But many people try to have a family mealtime. Other times that's just not possible. It's really hard with my family because my kids have different activities or appointments or whatever. For all of us to actually be here at mealtime, it's kind of rare these days. But maybe that's a very important thing for your family, and you want to incorporate your child into that however you can. So we can think about oral feeding. Is your child being fed? Are they working on self-feeding? And just thinking about that as a progression and a spectrum. And we might kind of go up and down with that throughout our development and throughout our life, depending on our needs. And then tube feeding, we want to think about how is our child who's tube fed participating in mealtime. I know at school, so mealtime is a really social time. We want to have the students, facing one another. We want to encourage that communication, that just noticing our peers, and that's a good time to do it, whether we're eating or not. So that might be something that you would do at home too. We also want to think about positive oral experiences, because especially our kiddos with medical needs, they've been through a lot of, bad medical experiences, bad oral experiences. They've had a tube in their mouth or their nose, and they've, had people poking and touching and prodding. And, a lot of us don't like going to the dentist. Well, a lot of our students have been through a lot of that sort of thing, and therefore are, don't want anything happening around their mouth. And if they haven't had those normal experiences of eating all of the food that we progress through, they haven't developed the same skill in tolerating that type of experience. And maybe they have a hyperactive gag response, or maybe it only takes a little bit and they're turning their head away. Or maybe they really like the oral things. A lot of our students do really like putting things in their mouth, exploring things with their mouth. So there's students who are tube fed. Can they have taste? Sometimes that's an option. So that's something that we will help with participation at school. And maybe you're doing that at home too, if it's safe. Okay. So feeding is a very complex process. And this is a slide that we shared with our OT PT department. And this doesn't even cover like half of it, but it sort of, goes over the basics. So anatomy and physiology, we're going to go over. That may be impacted by their medical diagnosis or not. It could include their stomach, their GI system. It could include their neuromuscular system, the brain. It could include actual oral structures. And it might be impacted by like their muscle tone and things like that. And those factors will impact the sensory motor system. So that's kind of included in there as well. So how we're taking in information from our mouth, from our tongue, from our hands, and then how we're interpreting that in our brain, and then coming out with that response of being able to move our lips and our tongue and our cheeks and our jaw to manage the food in our mouth. So social interaction, we said mealtime is a social thing for most cultures. At school, it includes students, paraeducators, teachers, and other staff. And like at home, that may be different. There may be siblings, it may be grandparents, maybe there's special holiday meals or things like that that are important to your family and your culture. Like I said, the environment may be very different at home and school, even down to, how the child is positioned. Maybe at school, maybe they're sitting in a Riften chair. At home, maybe they're sitting on a couch, so that can really impact their level of skills and independence. You might have different feeding tools at home. You have different cups that you use. You have a different fork. And, if there's things that work at home, it's really great to communicate that with the school and share those things with the school. Because we definitely want to be consistent as possible, because it is hard for kids to generalize skills from one setting to another. And definitely doing as much the same as possible can be helpful. And then at the same time, when we find something that works at school, we would hope to be able to communicate that to you to be able to use at home. So our experiences are part of that complex process, because the things that have happened to us or the things that we have been able to do in our development greatly impact our current level of skills. If we've had those negative experiences, maybe, we were a preemie, we were tube fed, and then we were transitioned off the tube, or we had breathing issues, all of those things will impact our feeding skills, at that time as well as later. We could have positive experiences that will impact our skills. Maybe we had a lot of skills and then something happened and then we had, we regressed but then we had the skills before, so it's easier maybe for us to get those back. So those experiences can go either direction. And then cognition, which, kind of goes along with the neurodevelopment, so ties in with the anatomy and physiology, but just that impacts our feeding skills, because are we going in with the sensory as well? Are we aware, or do we know what's happening in our environment overall? Are we aware of our hunger? Are we aware of our, being full? Or are we aware that our stomach hurts maybe and we don't want to eat today, or we're having reflux? Do we know the sequence of eating, like that we would hold a spoon and we would scoop and then bring it to our mouth? And we think of that as kind of a basic thing, but it is a tool use. We're using a tool when we're feeding ourselves. So maybe we're more at the level of using our fingers, which is fine too. Our communication skills can impact that, making choices. What do we want to eat? Saying, no, I don't want that. Yes, I need more. All of those communication skills tie in. And, as OTs in the school, we definitely have to look at all of these aspects and try to do the communication necessary with all the team members, home, school, medical, to really help our students with feeding. Okay, so Mealtime is personal, it's family oriented, and it's emotional. I mean, it's tied to our basic need to survive. It's not only a social thing for us, but it's tied to our need to survive. So we obviously want to ensure our children are fed and that they're healthy. And, we know that's number one. We might have mixed emotions when it comes to mealtime. We might worry about the child eating enough calories. Maybe we're afraid of giving them certain things that they'll choke. But we want them to have a good quality of life, the best they can, right? So if they can enjoy food, we want them to enjoy food to the best of their ability. So sometimes we might put safety aside a little bit because we're like, okay, well, they love this. And of course, we're always worried about safety, but sometimes, you have a balance there. And as parents, as teachers, as therapists, we have to look at that balance. But, we definitely want to always come back to that safety, because if the safety is not there, then the enjoyment is not really real, because it's not really fun when you're choking, even if you don't know you are. So we're going to talk about that a little bit. And I have a video to show you about that. Hopefully the sound will work. I didn't see an option to share the sound, but either way, you'll see the visual. All right, are we doing okay so far, everybody?
Yes.
Okay, thank you. I have to get out of my little sharing screen in order to see you guys, so I appreciate it. Okay, so again, the psychosocial side, I reviewed this article when I did a presentation a couple years ago, and I just thought this is really huge for all of us. It can be stressful. Feeding can be stressful, especially if our kid doesn't want to eat different things we want them to eat, or maybe we're worried about how they're doing with eating, or maybe they could feed themselves more, but they want you to feed them all the time, and you're just not going to have that battle, so you're just going to feed them. So it can be stressful. It can take extra time, and that can play into whether we want to work on independence. Maybe mealtime is not the best time to work on them holding a spoon if that takes a lot of extra time. So maybe snack time would be a better time to do that, for example. It can take a lot of extra time to manage tube feeding, and maybe there's a mix of both of those going on. Financially, it could be more difficult to get the right kind of food, formula, supplies that you might need. The GI issues are definitely stressful for anyone involved. The child, that's a negative experience if they're vomiting, if they're having reflux, if they're having constipation, and all those issues affect whether they're going to want to eat, and then how much they can eat, and just adding to the stress and the thought about it. It's not like you can just say, okay, it's time to eat, eat dinner, eat lunch, and it's just done. You have to think about all these issues often. Nutrition, making sure they're getting enough calories and nutrients. It can be easier to deal with that with the G-tube because, you can know exactly what they're getting, right? Whereas if you're doing just oral feeding, you're maybe more concerned about how much they're eating and what types of food they're eating. It can even disrupt a mothering or parenting role because you feel like it's your job to feed your child, make sure your child is nourished and safe and happy. And that can be hard if you're having difficulty in this area. It can be really hard to deal with that disruption. The child's enjoyment or lack of enjoyment of oral experiences, tasting and eating can be stressful. If they enjoy it too much and they're putting everything in their mouth, then that could be a concern. If they're really not enjoying it at all, then you kind of want to try to figure out why and what you can do about that. And then it can disrupt family dynamics, mealtime and routines. If you're making dinner for the rest of your family and your child with special needs has different foods or different times they're eating, that can disturb just your whole family dynamics, and you have to figure out how to make that work. And then just wanted to share this, the benefit, if it's possible, even sometimes during the week, to include your child in family routines. We're talking about independence, but along with independence is participation. How can they participate? They're attending, first of all. So I like this: participation equals attendance plus involvement. So they're attending, they're paying attention, they're noticing, they're listening. Maybe they're tube fed, but they can be involved in some way. We're going to talk about that as we go. But it's meaningful for the child. It's meaningful for the family. It will fit into your family's culture. It can broadly include things like shopping for food, meal preparation, your mealtime rituals, eating, social interaction, and cleaning up. So all of those things can be part of it. And it's a valuable time for these kids. It's a great learning time for kids, and special social emotional time. So including kids who are tube fed in mealtime, this was like kids who could respond with communication, how they were feeling. And the kids were, when they were included in mealtime, they felt a sense of social connectedness and belonging. They didn't feel as lonely. And they used photographs and real objects and real food to communicate their needs and preferences, whether they were tube fed or not. So even choosing, I know some of our kiddos get to choose what goes in their tubes. So that's really cool. All right, so we're going to move into anatomy and physiology of feeding and swallowing. And we're just going to kind of brush over this a little bit, but this picture is really hard to see. It's kind of small, the names of everything, but basically it's comparing a child versus an adult's oral facial anatomy. And just looking at the differences, you guys can notice just the shape is different, right? So the position and the height of the larynx changes, the voice box as the child develops. And you can see that down in the throat down there. There's my pointer. Okay. Can you guys see my pointer?
Yes.
Yes.
Okay. Okay. And you can see like the actual palate itself like changes shape. So you can see as a child, it's like flatter and it's more bent for the adult, but the cheeks have a lot more like space in there. They have a lot more fat in there. So it actually like inside the cheeks, there's actually more fat pads. So when I said there's more space, there's actually less space in the mouth for babies. They have these fat little cheeks and it doesn't take as much movement for them to get the food manipulated in there. But like adults, our cheeks are thinner and we've got just more space to have to move that food around. So our tongue has to be able to move and manipulate more. It needs to move it to our molars. It needs to push it back more. So by like 6 to 12 months, at 6 to 12 months, the soft palate does not approximate to the epiglottis, which, let's see if I can point to this. I cannot even see on here. Here we go. Here's the epiglottis here. So there's the soft palate, and you can look over here and look how much farther. I think that was a typo. So it actually goes right to the epiglottis. So when you're swallowing, there's less work that you have to do to close off your airway. But when you look over here at an adult, you've got all this space here, and it's more work to swallow. From 12 months to 5 years old, adult-like swallowing starts to occur. So by 5 years old, your anatomy allows for that adult-like swallowing. So you're swallowing, if you have like a swallow study done when you're an infant, toddler, early preschooler, the actual anatomy is different than when you're over 5. So sometimes there can be changes in the way that you're swallowing after that age, and it can be due to the consistency that you're eating, maybe. It can also be just the change in anatomy. So that's why it is important to have those swallow studies done, as the child is getting older, to see what has changed. And sometimes that can improve. Sometimes it can be more difficult. But it is important either way to know what's happening inside, because we can't always tell what's happening just from observation on the outside. Okay, I'm going to change to the next. Okay, so there are really 5 stages of eating. So first oral, where we're putting the food in our mouth or managing it. Then pharyngeal, where we're starting to swallow. It's going back, and we're shutting off our breathing tube, and it's going down the esophagus, hopefully. Then it's esophageal, and then we're digesting it in our stomach. It's going through our intestines, and then we're eliminating. So there is a video. Gonna see, let's see. It's taking a minute to load this video here. It's in your slides and you guys can watch it. If not, you're gonna see the swallowing hopefully on the video of the modified barium swallow study in a couple minutes. I don't know why this video is not loading here. Okay. Yeah, it's not showing up. There's a video over on the right side. It does not appear on this slide for some reason, but it will be on the slides that you get, and it goes over each step of swallowing. It's kind of nice to watch, but it is like 5 or 7 minutes long or something, so we don't have to watch it right now. But basically, this is showing the pharyngeal phase where basically your nose and your larynx are closed off, valved off to prevent food from entering your airway. So if you've ever choked or like inhaled your food through your nose, this is how it goes wrong. But basically we want it to be valved off so it doesn't go that way. That it would go through that pharynx, the tongue would move backwards, the pressure will propel the food, your soft palate will elevate, close off the nasal airway, and then all that action will bring it down to the esophagus. Your epiglottis tilts to cover the opening of the larynx, which directs the bolus, which is what your food is called once it's all put together, towards the epiglottis. You have your larynx elevates, all of this, like, there's so many things that have to happen for it to go the right direction. So you can see that when a child or an adult has any problem with their muscles or neurodevelopment, that this process can be delayed. It can not be coordinated correctly. So often that is a difficult thing. All right, so that's why that leads us into aspiration. When we talk about safety being like the most important thing, and I still see, so this is a video too. I don't know why my video is not showing on here. You guys don't see it, right?
No, we don't.
Okay, I'm gonna try to get out of presentation mode and just see if, okay, so we're on here now. You can see the video?
Yes.
Okay, so I'm gonna just play it from here. And we'll just watch it here, but on the left, you'll see the normal swallow, and on the right, you'll see the abnormal swallow. So it kind of goes quick. So I'm gonna go ahead and hit play. Okay, so now we're looking at the right. And you see how it's pooling there. Okay, that was pretty quick. Do you want me to play that one more time?
I think one more time would be good.
Okay, because it's kind of like you have to shift your attention. You have to look at the normal swallow first, and then when that's over, quickly look at the abnormal swallow.
Yeah.
Okay. Okay, so you can see the esophagus is in the back here, the trachea is in the front, so it went down the right way. And now you're looking here. Okay, so you're getting a lot of aspiration there, and that looks like a liquid, and it's going pretty quick. So you can see how quickly a liquid moves. I'm gonna come back to the slideshow. Okay, so, oh, and now it wants to play. How about that? Okay, so before we actually notice signs of choking or aspiration, we might see signs of stress feeding in a child. So there might be, a change in their color. It could be mild, or it could be a sudden change. There might be a change in their alertness. They might get irritable or drowsy, or just a change overall, depending on the kid. There could be a change in their breathing. Maybe their nose is flaring, their nostrils are flaring a little bit. They're having trouble. You can just notice something's changed. Or there may be excess drooling, gulping, gurgling sounds, coughing, choking. Those are later signs. But depending on the kid, if you know your kid and they don't usually do these things, a lot of these can be troublesome signs anyway. But if if you're noticing these during eating specifically, maybe it's stressful for their system to eat and something is not happening correctly inside. So signs of aspiration, with a thin liquid, you might hear a wet voice or gurgly breathing. They might cough. And then studies show that kids may or may not show the same symptoms with a puree as they would with thin liquids. Like it might not produce a cough or the wet voice. And their cough reflex might actually be impaired. So they might not cough at all. So coughing is actually good because we're trying to get that up. We're trying to get it out. So coughing is good. That's what we would do if we choke. But again, if we're seeing that a lot, then that would be concerning. There can be silent aspiration that we may not know that they're doing this. We may only be able to see it by that video that you saw, that's called a modified barium swallow study. So there's different types of aspiration, a little bit, a lot. It could be chronic, that can result in pneumonia or other respiratory things. So it is a big thing. It's a big concern. And if we do notice these kinds of things at school, we definitely want to communicate with parents. We want to talk to the medical team. We want to find out if you've had a swallow study and how long ago it was. And what I do notice is a lot of people don't have them as they get older, but perhaps it would be beneficial to have them just so we have all the information that we need to keep our kids safe, healthy, and happy. So dysphagia or swallowing disorder, they have OPD, oral pharyngeal dysphagia, was present in 85% of kids with cerebral palsy. And depending on the degree of motor impairment, there's more likelihood of having it. So just keep that in mind. Again, it says the modified barium swallow study can reveal that silent aspiration. So it's a real guide for feeding therapy. So if you get feeding therapy at outpatient or hospital, they're going to want to do this. At school, we have to get away with not having all this information at our hands, and that can be, a problem not having all the information. So sometimes we will like to ask for more. So we're going to jump in to self-feeding now. We're also going to look at the oral motor skills involved with feeding and how to improve our participation and independence with that. And what's important about this is looking at the order versus the age level, because a lot of students are not going to go all the way up to this. Maybe they're only able to have finger foods, or maybe they're just more drinking versus eating solid foods. It totally depends on what texture we're allowed to have. It also depends on our motor skills. If we're not going to hold a utensil, then we're not going to get to the last level here, but it just kind of gives a guideline of things that we would want to look for. So if our kids are using a hand to mouth pattern, well, we know they can bring something to their mouth, and we want to work on that. So we want to kind of think about this as maybe we could work on the next level if that texture is appropriate for them. So if they're already, sipping from a cup, maybe we want to work on them starting to hold the cup. If they are finger feeding, maybe we want to give them a spoon to play with. And then eventually we're going to start bringing that spoon to our mouth. And then the fork would, come later. So all the motor skills, needed for feeding, we have to have that strong base of support. So if we don't have it in our body, we would find it with our equipment and positioning, because our mouth is like a fine motor thing. So we have to have all of our gross motor stuff in alignment and as strong and stable as it can be. If you try to eat while you're lying in a hammock, it's kind of hard. So if you can sit in a chair with a back, it's a little easier. So if you think about that, and then what skills do we have that we can use towards our independence with feeding? Do we have good skills with our hands? Then maybe we really want to work on this self-feeding. All right, so 8 sensory systems. I'm just going to bring this in because as we talk about motor, sensory is really underlying the motor skills, because if we're not taking in information from our environment, we can't produce that motor output. Our brain works like a computer. We have to have the input in and then the output comes out. And we actually have 8 sensory systems. So I bet most people cannot name them all, but I think they should pop up if I click this. Let's see. Okay, so these are our basic 5 senses: our touch, our vision, our hearing, our smelling, and our taste. Those are the fancy words over there. And then, in addition to those, those are all important for feeding and mealtime, we've got the 3 body senses. So we've got proprioception, where our body is in space. So Is my arm bent or straightened? Is my mouth open or closed? Some of us don't have great proprioception. Maybe we sit with our mouth open because we don't really know what it feels like to have our mouth closed all the time. Vestibular is, where is my position in space? Is my head upright? Is my head tilted to the side? Am I moving or am I sitting still? Do I need to move around or can I stabilize myself? That's our sense of balance. And then lastly, interoception is our sense of our body organs inside, which definitely plays into eating, because if we can tell if we're hungry, we're going to have more desire to eat. If we can tell if we're full or if our tummy hurts, we might not want to eat. So interoception is an important sense. And we can be under-responsive or over-responsive in all these areas. We all have our preferences and needs and fall somewhere on the spectrum. And this is a whole nother talk. We're not going to go into any more detail today, but I just wanted to throw this out there because it does play a lot into our students and our kids, into whether they want to try new foods, whether they like to eat, don't like to eat, can sit still to eat, need it quiet in the environment, or like a lot of stimulation. There's all these things play into it. And then in addition, we want to think about, like, this kind of goes into the interoception. If we've got reflux, this really can impact our feeding. And we know a lot of our students have reflux, have constipation, have GI issues, which can really be negative towards feeding. So I'm not going to go over this slide in detail, but just to throw that out there. So when we want to set up the environment for the task, we want to think about, at school, we want to think about the environment. For some students need less. They don't need the screen on. They don't, maybe they need to sit in the back of the room. If we want to be more social, maybe we can sit with our friends. Maybe some background music is nice. So think about what works for you in your home and what supports your child to eat in the best way that they can. Because we do need to pay attention, especially when we're working on the motor skills of eating. We need to be able to direct our attention inward and towards our body. Because if we're directing it outwards towards what we're watching, we're not always paying attention to what our body is doing. And we may need to pay more attention to that. Okay. And so positioning, like I said, at school, we have our equipment that the student is in. You want to think about at home. And if you're helping the child, it's nice to sit to their side or kind of behind them so that you're not intruding upon them and sitting like across from them and trying to reach into their space to feed them. But if you're actually helping them maybe hold a spoon, having the caregiver sitting beside the student or the child, maybe to the side of, like if they're using their right hand, you would sit on their right side so you're not reaching across their tray. So thinking about being as least intrusive as you can be when you're assisting. Even if you're feeding the child, maybe you're sitting beside them and you're eating too, if that works for you, to not hurt your back while you're doing it. You want to think about just making sure their body is stacked up, like all their spine is upright. The blocks are stacked, I say. The chin is in a neutral position. A chin tuck is good for swallowing. We don't want to have him lying back too much because that actually opens up the airway when you swallow. It makes it much harder to swallow. If you try swallowing that way, it's difficult. So looking at the oral motor skills, what are we talking about with oral motor? So we're talking about our jaw opening, closing, and then rotary movements are really what we use for chewing. We might use an up and down movement for munching. So can we grade our control? Do we use like big jaw movements or can we use smaller movements? Do we have awareness of like feeling what is the texture, the temperature, how much food do I have in my mouth, or do we like stuff our mouth full? Do we have the lip movements? A lot of our kids have like the jaw movements, but maybe they struggle with the more fine motor control of the lip movements and the tongue movements. And that can impact safety and that can impact the textures that we're able to manage. So we want to encourage lip closure because if you try to eat with your mouth open, it's harder to do, first of all. And also you lose a lot of the food coming out and you may be losing saliva as well. We want to look at tongue movements. Can we move our tongue up and down and in and out and side to side? And we know that to swallow, our tongue has to press up against our palate to press the bolus, the food back. And we know that when we're chewing, our tongue has to move side to be able to find where that food is in our mouth, move it to the teeth to chew. So if our tongue is not moving a whole lot, we don't want to be offering textures that require moving around. So like a puree doesn't really require it to be moved because it's just in your mouth, right? And when you swallow it, it joins with your saliva and goes on down. But if you've got a chunk of something and you're chewing it, and then let's say that chunk moves around in your mouth and your tongue's not able to find it and then direct it back to your teeth, well, that chunk is now a choking hazard. So that's why these skills are super important. And you can work on these skills. There are some exercises and things you can do. I think I have a slide on that. But looking at just what skills are required, so like thin liquids, babies, usually start with these, right? Milk or formula, and babies have that sucking pattern. It's a reflex, and those require, lip closure, but that back and forth tongue movement to suck. Sometimes thin liquids are not always safe for people who have swallowing issues because they move so fast. We saw it go down the wrong way. Well, thin liquids just go really fast. There's nothing to stop it. Something thicker, so I have thicker liquids here, allows for that increased processing time. So if we're having trouble with thin liquids, then maybe we can try thicker liquids. And that's something to find out with a doctor and have a swallow study to find out the exact thickness that works best, because that depends on the person. But sometimes that could be a smoothie or a milkshake, or there's a thickening agent you can add to things. Pudding is a different texture. There's a little more increased tongue movement. If you're having pudding, you have to be able to kind of move it around a little bit or you're going to gag on it, right? So there could be a gag reflex with that type of texture. Some kids just don't like that. And then if you're mixing in some small chunks, well, then you've got a little bit more to have to move around. But again, it's not going to require a ton of chewing. You're going to be able to kind of manage just swallowing that. You got to have that sensory awareness. Soft mechanical foods are easily dissolvable, or soft cooked vegetables, eggs, canned fruit, maybe a graham cracker kind of dissolves when you suck on it. So you have to have a little bit of jaw control to take a bite and chew. Your tongue has to be able to move a little bit. You should be able to manage your saliva a bit when you're eating this, but it's not going to require a ton of action of your muscles to chew it. But then regular food really does require that sensory awareness, knowing what texture it is that's coming in your mouth, motor planning and timing all those movements to chew, move it to the right place, get it into the right consistency to swallow. So I would say regular food, unless we don't have any of the oral motor concerns or swallowing concerns, like we're probably not giving our students or our children totally regular food. We're adapting it in some way. And, the choking hazards, the big choking hazards on the bottom, the popcorn, nuts, raw carrots, foods with the shell or skin, just because if we're at any bit of a risk for swallowing issues, I would not want to see our kiddos try these foods. And also they can take a lot of energy to chew too. That's the other thing to think about. If our students have limited energy, we want to conserve that energy for learning, for other things. So we might not want to expend all of our energy chewing raw vegetables. Even if we can, it might take us like 45 minutes to have lunch because we have to chew all of that. So we want to consider that also in our textures. So supporting those skills, maybe our mouth is really not like ready or like aware or awake. So if our child enjoys it or likes touch to their mouth, you can play little games with like a washcloth, or you can, give their lips a tap, or there's very specific techniques. I'm not going to go over these special ones called like the Beckman stretches. There's special things that you can learn with a therapist if you go to feeding therapy. But there's things that you could just do at home, even just giving like little prompts or cues, like if you're noticing they're not closing their lip, oh, here's your lips, or like, silly faces, like playing with something, like if they like, their toothbrush, you could play games with the toothbrush, sometimes an electric toothbrush. So there's different things you can do that you want to keep it positive. You don't want it to be a negative experience for your kiddo. And sometimes giving a little support to the jaw can help, like just to be like, oh, you need to close your jaw, But studies have shown like the more like it can kind of impact feeding and maybe make it more likely that they're going to do poorly with feeding if you're doing too much of that. So you want to look at the kid and what are they able to tolerate? What do they enjoy? Just some tips when you are feeding a child, if you're doing the spoon feeding. There's a little video here I'll show, and you want to give wait time. Wait time we talk about for everything, right? But wait time also for eating. We don't want to shove the spoon in. We want to make sure they're ready to open their mouth. Midline is usually a good place to come, unless we know that one side works better than the other. But a lot of times we want to come to midline. We want to go straight in and straight out. We don't want to pull up necessarily. We want to try to pull straight out and let them try to remove the food. Give them time, wait time again to take the food off. If they have like a tongue thrust or a tight tongue, we might do some downward pressure on their tongue. And then we don't want to just keep wiping their mouth the whole time because that's going to disrupt the whole feeding process. So just a little pat or like kind of give wait time for that too. So there's a quick little video. We only have a few more minutes left. This time is going fast, guys. Can you guys see it on there? I'm just going to play this little video here for time's sake. But you can see there's, this is a mom who's feeding the kid, and then the therapist is going to tell her. So she's kind of pulling it up. Okay, so you saw the child was like extending her head back, and then she's saying, hold it there and then press on the tongue. And she's using a maroon spoon, which is a spoon that we often use at Longview, and you can get those at home. Oh. Okay, so she gave a little bit of wait time, and then she pulled straight out, and then the child therefore wasn't tipping the head back. Because remember, we want the chin to be a little bit tucked. Okay. And then to support, like if we're working on biting and chewing, we want to think about those easy to bite foods that dissolve. We can hold it and have them work on take a bite versus just putting it in their mouth, like have them actually use their teeth to take a bite. So graham crackers or veggie straws might be appropriate. And this, again, this totally depends on what they're kind of cleared for medically. You can use those nice chewy tubes that we have, like to work on biting and chewing. If they're interested and willing to do that, you can put a flavor on it so it's more interesting. You can move it side to side to work on their tongue moving. You can see if they can give it a kiss, if they can imitate movements. You can work on lip closure. And then the other thing is looking at their mouth to see if they're pocketing food, if there's residue. Some kids benefit from having like a little sip of something in between a few bites to help like wash that out. Or maybe they just need to be told, oh, you still have food in there, chew, chew, chew. So this is just a general texture progression. Again, like it's the order versus the age, but we kind of talked about that already. I'm going to skip over that. Okay, so just real quick to mention the non-oral feeders, things that we can do to support their skills. Dental care definitely is important for everybody. And, working on that at home. Positive and pleasurable oral stimulation if they will allow it, like even just giving kisses, touching their face, just keeping this like a happy place. Because we're going to have to get in our mouth for certain things, and we want to keep that happy. And then saliva management, or supporting like speech or vocalization, we can work on that kind of stuff. Definitely like awareness. Oh, you're wet, and then we can take a towel and just work on, drying off, just all of that. But we want to keep it positive. Sensory considerations. We mentioned sensory before, but just looking at what are the preferences? Like what does the child prefer? Do they like sweet things? Do they like spicy? Do they like bland things? If they're not really aware, sometimes it can help to add a little more flavor. Maybe it'll wake up their tongue and be like, oh, I can taste that now. Or maybe something cold will help them stimulate their muscles. And then you want to look at the whole environment. And, if you're offering new foods, you may want to have them explore it first. They can look at it. They can touch it. They can do a lot of things with the food before they're actually eating it. So that's why participating in any kind of family meal time can be helpful in any way that they can. Okay, so finger feeding. Finger feeding is a really important stage. So we don't always want to go straight to using a spoon. And even to like explore a new food, if they're not going to be able to hold a spoon, maybe they can still play with the texture on their tray while you're feeding them. So they're feeling it. They're getting an idea of what is this that I'm eating? What does it feel like? What does it smell like? That can be really helpful. And then if we're holding something like a solid food, if you hand it to the child, that can help facilitate their grasping. It's sometimes hard to pick something up off of a tray. We might use a raking grasp to get a handful of something, but just to get one thing, that might be hard. So if we're going to hand it right to them, maybe place it on their thumb and maybe they'll be able to grab it and then bring to their mouth. And again, like if we're feeding a child a finger food, same with the spoon, we want to give that wait time, allow them to open their mouth to accept it and to take a bite. We don't want to just like shove it in their mouth. And then if we're working on them getting it off the tray, if we have visual issues, maybe we want to look at a contrasting background. I'll show you some placemats and stuff we use at Longview. All right, so moving on to the spoon. You know, we want to think about foods that stick to the spoon, especially if we're working on independence. If we're working on us bringing the spoon to our mouth, we don't want to use soup or something that's just going to like be really difficult to manage. We want to do something like pudding or applesauce. There's lots of adapted spoons. I have a slide of in a moment. Maybe if we can't maintain a grasp of a spoon, maybe we could use a universal cuff, or there's easy grip handles. I have a picture of also on the next slide. We want to use our prompting strategies, our wait time. We don't want to just like do it for them. We want to see what are they able to do and then do the least amount that we can to support them. Maybe they just need help under their elbow, or maybe they just need a little support at the wrist to kind of like get that last bit in the mouth. Or maybe they'll put it in their mouth and then they let go. So they need help to like keep their hand there to pull it out. So we want to see what are they already doing and just do a little bit to progress that. Here's some adapted spoons. So on the left, you see the maroon spoons, and those have a nice flat bowl so they can make it easier for the mouth to remove the food. You can see the curved spoons, and often those are helpful because we don't have the full like wrist rotation to get that spoon oriented to our mouth. We have weighted spoons. Maybe we need more sensory input to feel that. We can build up the handle. And then you've got the cuffs on the right side, and the bottom ones are the silicone cuffs, which are really super fun, adaptable things. We have lots of those at Longview for all kinds of different utensils. And those are great because they're so washable and reusable. Okay, so fork, same thing. We want to have forkable foods. So what stays on the fork goes in, right? So if we have like a mixed texture or something that's really just too soft for a fork, it may not be the best food to try working on a fork. A lot of times stabbing the food is the hardest thing to work on, but maybe if we already put the food on the fork, maybe they can bring the fork to their mouth. And I know some students who do better with a fork than a spoon. So you just never know about this. It depends on the student. Again, you can have a curved, a long handled, a weighted fork, any of the same options with the spoon. And whatever works for the individual to hold it, it doesn't matter how pretty it is. If it works for them, that works. Okay, I don't have any pictures of forks, but they're pretty similar. Then looking at the bottle versus the cup. So this again goes back to that swallow study because we really don't know what's happening behind, you know, the skin of the neck. We don't know what's happening in there without having that study. We can observe, but we don't always know. And that sometimes like a thin liquid might be what we notice a choking on. I know if I'm tired or, you know, I'm drinking something too fast, I do tend to like cough on that. And, you know, we can all have those tendencies, but thin liquids can definitely be easier to choke on. So if we're using a bottle or a cup, we want to think about if we had a swallow study with like a bottle, like the pattern to drink from a cup would be different. So we want to think about that too. But as we progress to a cup, we want to think about having the child work on holding it if they can. You know, if we can bring our hands to our mouth, we can find a way to hold our cup or whatever it is to bring to our mouth. We can look at the size, the shape. Does it have handles, the lid? What kind of oral motor skills are they using? Are they sucking from a bottle, or do they have a little bit of lip closure that they could do a straw, or they could do a cup with some sort of a lid? We want to think about straws, like as long as their swallowing is okay. Sometimes that can be controversial, but it also can help them to tuck their chin to suck from a straw. So it kind of goes both ways. There's a lot of good adapted cups, and there's on the left you can see the nosy cups that have the little cutout. And that helps, it's just, you know, regular open cup, but it's got a little cutout space so that when you tip it back, there's a place for the nose and you don't have to tip your head back. So you're keeping that good head position. There's the cups with the lid that control the flow. There's the, you know, handles. And then you've got the honey bear cup, which is nice to work on the straw because you can squeeze it. And you can actually make this if you get a honey bear and use the honey and then, you know, save it, clean it, and then get a, you know, straw you can put in. And you can work on squeezing to help help it come up. Same kind of thing with the juice box, except the juice box is super thin, so it's harder to close your lips on. And then this is called a reflow cup, the one on the bottom here, the blue one, and that controls the amount of liquid coming out, but it really looks like a very normal cup. So this is a nice one for some students. Okay, and then just some options of plates and bowls and placemats. So you can think about like if the bowl is like moving around and we are able to like work on scooping our food, then we might want to have a suction cup, or you could get a like a shelf liner, or we have something at school called Dysum that helps things not move. A plate guard or something just to like push against can help you scoop, right? Especially our kids who are visually impaired, it helps to have that feeling of like, okay, this is the edge of my plate and I can scoop against it and get my food. For visually impaired kids, we want to have food in the same place every time so they know where to find their food. A divided plate can be helpful. This placemat over here is nice too. And they have those with like a single compartment or multiple compartments. Okay, so other ways to participate in eating. Remember, even if we're tube fed or we're not able to do a lot of the other things, can we help set up the food? Can we pour, scoop? I love washing like vegetables and fruit because most kids like water, and if we can access a sink, that can be a great way. Maybe they can drop the food in the colander. They're working on grasping and releasing. They can maybe put their hand under the water and help wash off the stuff. Maybe they're stirring. Maybe they're setting things on the table. Maybe they're helping to put like a bandana on or something, or maybe they're opening a drawer because that's really fun to open and close drawers and cabinets. Getting something out, like I said, setting it on, making a choice. Maybe they can help choose things for the family, hopefully choosing things for themselves too, using those communication devices or pictures or whatever the method is for communication to request that they want more, or they're all finished, or they like, or they don't like. So definitely bringing in that communication. And I just want to mention hand underhand assistance, which is something that we do use a lot at Longview, and that can be better tolerated than hand overhand assistance. So especially for kids who maybe aren't able to hold a spoon or a utensil for whatever reason that is, if they're able to go along for the ride, I call it, then they can put their hand on yours while you're feeding them, and they're feeling the movement. They're getting that range of motion to bend their elbow and get that to their mouth. So that's hand underhand is a really nice way to support students, especially if we don't like to be touched, don't like to be helped, or have limited grasping abilities. That can be a great option, or even a place to start for a student who does have those abilities. Let's see, I think I have, okay, I wanted to get any tips or advice from any parents who are here. But I have references here, and then I have some more resources. I'm going to add to this a little bit more with some of the, I think I put the links in for many of the feeding utensils and things within those slides themselves, but I can also add them here at the end. But I wanted to close with if there's any questions or any comments. And I'm going to stop sharing my screen.
Well, thank you, Katie. That was really informative, and I always learn something when I hear you present. So thank you very much. I'm going to stop the recording, but that doesn't mean that there can't be questions.